Hello, and welcome to another episode of Vital Times, the CSA's podcast. I am really excited today to have four amazing guests join me. We are going to talk about a really interesting topic that to me, it feels like it just came up, but I actually realized that the initial statement around this topic was released in July of 2025. And that is anesthetic considerations in patients of Venezuelan ancestry. At the end of January, the American Society of Anesthesiology and the Society for Pediatric Anesthesia issued a joint communication regarding severe neurologic complications, including stroke and death, in healthy adult and pediatric patients of Venezuelan ancestry following routine general anesthesia. There have been about 36 known or suspected cases worldwide, the majority in South American countries, with 6 in the United States and 8 in Europe. This was as of the time of the joint communication in January. Detailed family histories of the patients who were affected revealed that they were all of Venezuelan heritage, and several had family members who also had adverse outcomes after otherwise uneventful anesthetics. So I'm joined today by Dr. Jim Fehr. Dr. Fehr is the past president of the Society for Pediatric Anesthesia and the division chief of pediatric anesthesia at Stanford's Lucile Packard Children's Hospital. Dr. Veronica Zogby is the Venezuelan pediatric anesthesiologist and director of the Pediatric Regional Anesthesia Service at the University of Miami in Florida. Dr. Claudia Bruguera is also a pediatric anesthesiologist and an assistant professor at Cincinnati Children's Hospital. Dr. Luis Rodriguez is a Venezuelan pediatric anesthesiologist from Miami who currently serves as the vice president of the Florida Society of Anesthesiologists. And these are some of the people who are kind of at the leading edge of expertise and knowledge in this disease. I'm going to start with Dr. Fehr, who is one of the co-authors of the initial statement, and ask him if he could explain to us sort of how this came about, where this all came from, and what are some of the things that we should be aware of. Dr. Fehr.
Dr. Agarwal, thank you, and friends and colleagues. The joint statement came out on July 31st, 2025. This was a joint statement from the Society for Pediatric Anesthesia and the American Society of Anesthesiologists. And it stemmed from reports from the Society of Anesthesiology Chile, the Venezuelan Society, the Colombian Society, as well as cases that were coming from Spain. SEDAR was the Spanish organization representing anesthesiologists. And what was noted that there were children that were previously healthy that would have apparently uneventful anesthetics, and they were dying after these anesthetics. This ultimately led to investigations, and the Spanish group, the Zaragoza group, was able to identify ultimately a point mutation, the ND4 gene for mitochondria, which is a subunit of the complex 1 of the mitochondrial electron transport chain. And further investigations were continuing into what was the common etiology. The reality is there's very little published about this at the present time. There are case series that are coming in that will be published soon, but most of this has been by word of mouth. And the SPA and ASA felt that it was very important to have at least an alert that would notify membership and the larger anesthesia community throughout the world that patients are vulnerable, that this mitochondrial mutation exists, and that mitochondrial mutation could take a otherwise appearing healthy child and result in a catastrophic day for that family, for that child, and the anesthesiologist.
Wow, thank you. That's pretty remarkable, and it's pretty remarkable that the ASA and the SPA were able to put this together. I'm just going to ask you one more question, and that is, Was this something that SPA became aware of? And that's the Society for Pediatric Anesthesia, for those who don't know. Was that something the SPA became aware of first, or something that the ASA became aware of first?
I think it actually was our South American colleagues who were aware of it first. What I've heard by word of mouth is a series of kids were affected in Chile. And one of the commonalities is they were all of Venezuelan heritage. The the maternal grandmother were from Venezuela. And further investigation and looking throughout the literature, not finding anything, and then word of mouth, there was discussion. So it was others. It was our colleagues from South America that raised our awareness. And unfortunately, some cases that happened here in the U.S. that made it very clear something should be stated. So this was ASA and the SPA in concert, working together to try to raise awareness to protect future patients.
Wow, that's really awesome. That's pretty amazing to hear two big organizations like that come together so quickly and put out something. I'm going to move on to my Venezuelan colleagues, and Dr. Claudia Bruguera is also Venezuelan. I'm going to ask her next. What type, if you know, of neurologic complications are you talking about? I know it says stroke and death. Is there anything else that you've been seeing? And also tell us a little bit about how you got involved in this area.
Hi, Rita. Thank you for the opportunity talking here. Yeah, so we know so far that these kids have presented with neurological complications, but we've been asking patients, providers, some of these families, and try to collect and gather some of this data. And we have realized there is a wide range of these neurologic symptoms we're talking about. The most common thing and the first thing that we'll see in these patients is delayed emergence. When we ask how much delayed emergence really, well, we have heard about as much as 10, 12 hours of delayed emergence in these kids. Some of these kids don't even wake up at all. But if they do, they had some neurologic injury. So I have seen wide range, mild to severe neurologic complications. Mild things like altered mental status. These kids are irritable at home after. Some of these kids have headaches. They can present with vomiting. And then for the moderate symptoms, things like weakness. Ataxia is very common, and they present with motor deficits, dysarthria, dysphagia, or new onset seizures post-op. Some of these kids even come back for subsequent studies, and they end up having MRIs or lumbar punctures. Some of these procedures are done under general anesthesia, and they either get worsening of these symptoms or they even die in the second or third anesthetic. And then we have seen these kids that after the first anesthetic, they have severe neurologic symptoms, hemiplegia, quadriplegia. Generalized dystonia is very, very common in these kids. And you can see spasticity, of course, cerebral edema, even brain death.
So you've had patients yourself that have gone through this and had these symptoms and signs.
I have not. I have not seen patients myself, but I have been really involved in talking to a lot of families that have gone through this. And we've just been collecting data. So through personal communication, we have been very desperate, try to grasp, as much information as we can about this. And by collecting data on these with these families' information, we have learned a lot about the clinical manifestations of these patients.
This is so fascinating, and I have so many questions, and I'm sure our listeners do as well. But I know it's going to be hard to cover everything. Dr. Rodriguez, why have there been no case reports in Venezuela, or why have we not heard of this until now? Oh, and also, can you talk about what your involvement, how you got involved with this community and with this topic?
Well, good afternoon, and thank you, Dr. Iowa, for the invitation. So let me start with the second question, and that way sort of tag along into the first question. So I got involved because in June of 2025, when the Chilean Society of Anesthesia released their communication, as you can imagine, since 2010, 2015, there's been a massive exodus of Venezuelans out of the country, looking for better opportunities, the challenges with the healthcare system, and all that we know that has explained the political situation surrounding Venezuela. And it is through our colleagues and friends from medical school who did anesthesia, who work in other countries, that we started getting these communications, and we started thinking like, this is interesting. So we started looking at the mutation. We were able to get a hold of all the documents they had been investigating, the proposal of the study from the Ciber's research group in Spain, led by Dr. Eduardo Ruiz Pesini, who had his proposal of the first case series of 8 patients, all from Venezuelan maternal inheritance. So we started looking at this, and we realized that in South Florida, we had a pretty similar case that we were involved at some point, and we started looking at the studies and things like that. And we realized that some of our colleagues through the FSA were reporting similar cases that had happened previous years, even from 2020. And when we reviewed with them the data of their genetic studies, we found that they shared the same mutation in the ND4 complex of the electron transport chain of the mitochondria, similar or not similar, with the exact same mutation as those patients in Spain and those patients in Chile. So through them, I got involved, and then slowly we were able to put a group of researchers, geneticists, all Venezuelan pediatric anesthesiologists, critical care, some adult anesthesiologists, but all Venezuelan origins, that through our chat groups, we had something in common, which was we have to prevent the next case happening. So it is through that point that since probably mid-July, August, we got together and we put up this group, which we have been working. Going back to your first question is, why didn't we hear this before from Venezuela? And I have 2 points that I like to make clear. And it's the same, it goes by hand in hand with the reason why suddenly we start getting that in 6 months, we now hear that there's 10, 12, 14 cases in the US waiting to be verified. And it's because, as you can imagine, any case that comes with a apparently healthy patient and has such a devastating neurological outcome is not going to end up in a scientific journal immediately. We'll probably go through legal and administrative protocols and reviews that might put that data away from any potential review from other sources, or the legal department just hides that record. So it has been a sort of like finding a needle in a haystack. And even when we find the needle, doesn't necessarily mean that we're going to get all the data. So that's sort of, in general, the US and in Venezuela, some cases were hidden. And then recently, within the month of February, the journal The Lancet published a pretty well-written report or comment or editorial just discussing the current political healthcare situation in Venezuela and suggesting why none of these cases. And as some of you know, healthcare crisis in Venezuela has been happening for a long time. And this led that with the financial crisis and the government probably not focusing into the maintaining the basic healthcare system functions of reporting, creating epidemiological data that can be shared internationally, all this is gone. Nothing has been reported since 2016. So this will limit the amount of information we get, and also this will also limit the amount of information that you could get. There were some cases that people had historically heard in a particular population between, I would say, the early or like mid 2010s. So maybe around 2010, there was a group of patients that had this, but further investigation at that time, it was blamed on a bad batch of sevoflurane. So at that point, it was not investigated further, trying to pinpoint if there was any other cause, but it was blamed on the drug, the anesthesia gas, which we all know is sevoflurane, and it was pinned on that. So that's why I think, even though there were cases happening in Venezuela, we didn't hear about this. Also understanding that with limited resources, genetic testing, it's very challenging to obtain in the Venezuelan population.
Got it. I have a follow-up question for you on that, and I think you sort of answered it, and that is, most of the information, it sounds like, is coming from individuals talking amongst themselves, like you and the Venezuelan pediatric anesthesiologists, or reports, as Dr. Fehr had mentioned, from some of the South American anesthesia societies, and not from any published or peer-reviewed articles. Is that mostly because of sort of the legal barriers, or do you think there's anything else that's contributing to that as well?
That's a very interesting question, Rita, and I think it has to do mainly because when a bad case like this happens, hospital administrators, I think the legal department just wants to hide it, because for kind of like a knee-jerk reaction, we don't want bad representation to go out there to the media and say that we don't provide good care of our patients. And sadly, this is one of those cases where, when there is very limited information, anything that could have happened in the record will be grasped and used as the main culprit of the devastating neurological outcomes. Most of these cases share what would be considered some episodes of hypotension, but some experts describe this as not necessarily that could explain the level of hypoxia or ischemic damages seen in the diagnostic studies. So that is from one area. So even though when we find, and this is part of our group effort, is since there's a lot of noise, we have to really work hard in determining what's true or not, so we can help those who are publishing, and also to publish the most amount of cases with the most reliable data. So that's why we've been immersed in social media. When we see a family member describing, hey, my son had this episode, we have individually approached those patients or those persons, and then try to get a hold of that family member or that patient, get a hold of the record, or we've been able to get even the genetic studies, some of the results that the family is willing to share. On the other side, through the webinars we did with the Florida Society of Anesthesia, or some of the lectures we're all starting to give in different universities or hospitals requesting for information, some of our colleagues actually personally reach out to us and say, hey, I was the anesthesiologist of this case, and they have the information. And through that, now we're starting to get real hard backed evidence. So with this is how we've been able to, collect more reliable information.
Thank you. That is So fascinating. Dr. Zogby, the same question to some degree for you. How did you get involved? And my other question was going to be, we are all, I should say, because I'm also a pediatric anesthesiologist in this group, and so is Dr. Fehr. But this also affects adults as well, correct?
Hi, Rita. Yes, I would like to tell you how I got involved. First, as Luis was saying, I feel that when we first heard about these cases, we realized that we were in a unique position because Luis' generation and my generation immigrated to Europe and to Latin America. So we have a network of colleagues everywhere in the world. So when this first happened, I started reaching out to people everywhere. And that's when we started finding more information, and we realized that there were silos of information. And the best way to avoid wrong information being spread around, which if you see social media is already happening, it will be like creating a group so we could screen the information and try to confirm the information before being shared. And also to connect experts with each other. So we created this group that Luisa was mentioning. We created a name of vapor that is the Venezuelan Anesthesia Perioperative Risk Group. And then with this group, our goal was to share information between each other. In that place, Claudia has been very close, and Luisa talking to the family members that we have found. We have all tried to reach out to potential cases, but we have designated mainly Claudia to talk to the families. So that way we have like a standardized way of asking the same questions, and we've been collating that data. And then with that, we've been able to share information with different institutions and be able to create grand rounds to spread the information. So I think that has been very, very important because this is important to share with your institution. The best way that we feel is to create grand rounds that are combined and grand rounds that can be shared between anesthesia, pediatric, genetic, and surgery, because all the colleagues that are involved needs to know that this is happening, because even though that is rare, the outcomes are so devastating that we need to make sure that our colleagues are informed, not only in our specialty, because we're consultants. And when the patients arrive to us, they first have gone to the clinic in surgery and pediatrics, and we need to make sure that they are being approached the right way. Because as Luis can maybe tell you a story, we have found cases canceled because wrong things were said in the surgical clinic. So misinformation is the first thing that we need to avoid. And I think ASA and SPA were very responsible with their communications, knowing that there's not that much information, but we're willing to collect and try to share whatever information we find and keep updating those grand rounds so everybody keeps having updated information. Our group, our goal is to create a website where we can continue to provide in-time information for providers and also for families and for patients. As you were saying, if the adult patients may be at risk, there has been cases of young patients, young adults, I would say, around 31 to 32-year-old. So yes, this is for what we have seen is a possibility that young adults can have this disease and this mutation, especially if they have never received anesthesia. It can be important, to find out if they are at risk of having the mutation.
Great. Thank you so much. I see Dr. Rodriguez, or Luis, has his hand up. So if you'd like to add to what Dr. Zogby said, please feel free to.
Yes, and I wanted to comment because, as Veronica is saying, some young adults, and if we see the recent editorial sent from the Ministry of Health of Chile, if you look at the data, and that was published in Anesthesiology, I think between the last 2 weeks, I believe it was early last week, that editorial shows that in their age range of the 7 patients, their oldest described patient is 36 years old. So that's one so far is the oldest patient we can potentially prove right now. But through our communications, we know that we have a few that are between 20 and 30 years of age. So what's the age limit? It's going to be interesting, but I would not classify this just as a pediatric problem. This can also be a problem of the young adults, or as Veronica was saying, if a patient had never had anesthesia, are we going to find a case that might be in their 50s that was never exposed to anesthesia, that carries the mutation and could potentially have a side effect? We don't know. That's some of the answers we are really working hard to trying to answer.
Great. And on that note, Rita, what Luis was saying is that also right now is Venezuelan, right? Because in these decades, if we think that the mutation was started in our community, there's Venezuelans around the world. In 30 to 20 years, 20, 30 years, this may not be only Venezuelan, right? Because we are going to be, living in Europe and meeting other people. And then this is going to be a whole, nationality. It's not a nationality thing. It's not going to be only Venezuelan ancestry, right?
Right.
This is going to be spread in other communities because it's just like right now we have only found it in Venezuelans. That doesn't mean that in 20, 30 years it's going to be only that, right?
Right.
So I think that's a very good point to make.
I wanted to ask Dr. Fehr really quickly, because I don't think I mentioned it at the beginning, and we probably should do that. What are the primary anesthetics that seem to be the risk factor for this? Is it all of them? Is it just some of them? And if it's just some of them, are there recommendations from the ASA and or the SPA regarding what we should be doing to treat these patients safely?
Sorry. If I could follow up with what Luis and Veronica said first, as they had mentioned, or it has been mentioned, there were approximately 8 million Venezuelans who have left the country. It's about 20% of the population, the majority of whom, about 2.8 million, are in Colombia. The U.S. population has tripled from about 217,000 in 2010 to over 760,000. And the highest concentration is in Florida, and in particular, South Florida, Miami. But as Veronica says, this is not a Venezuelan disease or condition. This is a mitochondrial condition. And mitochondria, as we remember, inherited from the mother. So mothers become mothers because they meet somebody, and then babies are born, and the babies have mitochondria that are affected. What is affecting those? It seems primarily, as Luisa described, sevoflurane is the one drug that has been implicated the most. But most of this, I would say, this is medicine before the modern era. That is, most of what we know is right now word of mouth, which is how medicine always was until there was scientific data to support it. That does not mean this is not real. What this means is we are flying relatively blind. We are blessed because we know there's a mitochondrial mutation. But to answer the question, what's the right, if you would, cocktail of medications that would be safe? I would say, as with any child with a mitochondrial condition, a guarded vigilance would be the most safe approach. Certain drugs, specifically the volatile anesthetics, and specifically the one most commonly used, which in pediatrics, which would be sevoflurane, the ASA SPA statement is suggesting avoiding that. Propofol also impacts this complex 1, and these children have received sevoflurane in the past. Kids that have known that it's been shown that they have the mutation have received sevoflurane without incident and propofol without incident, but we don't have clear data who got what when, because as Louise was describing, the records in Venezuela are often paper, and there wasn't a national epidemiologic approach to some of the challenges of healthcare. So it is extraordinarily hard to get that information retrospectively. The group that Veronica described, Luis, is exceptional in trying to bring together experts from around the world to follow through with this. And the ASA is recommending that if somebody suspects or identifies a child that they know has mutation or they suspect does, to report it to the Anesthesia Quality Institute's Anesthesia Incident Reporting System, the AIRS. That is led by Randall Clark, former ASA president, SPA member, and former chief of pediatric anesthesia at Denver. There are drugs and there are medications that are considered more likely to be safe, such as midazolam, Precedex, ketamine, and short or ultra short acting opioids. They have not been implicated, but I would take that with caution, because when we don't know, what we know is what our friends from around the world have told us. And I think one of the reasons you don't see mitochondrial disease in adults is because they have a toll on the children who have it, and not all live the longest life, especially when they confront the medical system that is unaware of the challenge these precious patients represent.
Dr. Bruguera, I wanted to circle back to you, and I know that you have a question as well. But before that, we've talked about the labs. We've talked about the fact that we've isolated this genetic mutation is remarkable to me, given how this whole thing started. But are there certain places that do the testing? Is it everywhere? What do you do? How soon can they do the testing? I have a lot of questions around screening when you're concerned about someone who may or may not be at risk for this, and how realistic it is to actually do the genetic testing.
Yeah, if I can follow up on what Jim was mentioning about the drugs that we know. So we know for sure the sevoflurane is a trigger. We don't have enough information about other potential medications that could be triggered or not. But we have been in very close communication with a research group in Spain that they're about to publish hopefully soon. Preliminary data shows 90% decrease in oxygen consumption in mitochondria when exposed to sevoflurane. But interestingly, that does not happen with propofol. So they also tested the propofol response seems to not trigger the disease, even though we know that propofol has been shown to be impact the electron transport chain in mitochondrial disorders patients. So this seems to be behaving as a different mitochondrial disorder as the one we knew priorly. And also by communication with our friends in Chile, and in Venezuela as well, they have used propofol in subsequent anesthetics of known carriers for these after having the disease triggered by sevoflurane. And in these subsequent anesthetics, whenever they use propofol but not sevoflurane, the neurologic symptoms did not get worse. So I think this is important to consider that first, not all mitochondrial disorders act the same way, and it all depends where exactly the defect is to know what drugs can we use or not. We'll hopefully have more information in the future. But I also want to add we have options and alternatives. And there seems to be a nice role for things like maybe remimazolam that has very, almost no effect in the mitochondrial. Same as Precedex that has no effect in the mitochondrial. And then of your question about the genetic laboratories and how are they reporting this. So we have found a barrier this is one of our barriers that we have. So this variant, it's classified as a variant of unknown or uncertain significance. So the variants can be all the way up to pathogenic to benign, and this one falls somewhere in the middle. Because of this, the laboratories are not necessarily reporting this variant unless you specifically request. We have seen many patients that initially test negative. The result says negative for no known pathogenic variants that could be explained in this phenotype. But in reality, when they actually bother this laboratory and they say, like, can you please check if this is absent or present? And it turns out many patients have this variant positive when initially was screened as negative. So this is very interesting and thing to consider. I don't know if I answered all your question.
No, that was great. So if I understand correctly, and I just want to circle around, the all laboratories can do it, but you may have to ask them specifically to run, to look for this variant, because otherwise they won't flag it necessarily as being abnormal. Is that correct? Is that how? Did I understand that properly?
That is correct. Yeah, they might not flag it, or they might not release additional findings of variants in general.
I would say that not all labs, it's reference labs can do this. For example, Baylor, they can do that here at Stanford, Mayo, Cincinnati, but not every lab everywhere would be able to do this. And since the variant, unless they look for it, they won't know it is there. One of the reference labs saw it and thought that was just a normal variant. And the other part is these children can be cared for. If they come in with a broken arm, they can be cared for whether you have the testing or not. And that's important because throughout the world, not everybody has a genetics reference lab that you can send samples to. And you still have to care for these kids. And the final complicating thing is this will be a challenge because Ruben Azócar from the chair at Tulane, he's from Venezuela and has practiced many decades here in the U.S., but he said that not everybody has the ability to do TIVA throughout Latin America and throughout various areas of the world. TIVA is a reasonable approach to these patients, but this is going to be a challenge in how to provide best care, not just in the U.S. or in California, but throughout the world where these kids will be encountered.
Wow, it's not something that I had thought about. I guess we're so entitled and privileged in this country that it didn't occur to me that we couldn't do TIVA or IV medications in other countries. I'm intrigued by remimazole. It's not something we have yet here at Children's, at Lucile Packard, but hopefully we'll eventually get it. I know, Luis, you have one more comment, so let me have you do that. And then I do, as we're running out of time, I do want to ask some more practical questions, and that is, are you screening everyone, and what are you recommending for anesthesia? But let me have Luis jump in, and then Dr. Fehr again, or Jim.
So thank you, Rita. And to tag along, so a couple of comments with the recommendations and how I appreciate Jim's comment and how good we have it here in the US, where we have, even though we all wish we had target control infusions and using their protocols, which is not uncommon in Europe and some places in Chile. That's great. But since we started this and we've been talking to the Venezuelan Society of Anesthesiologists, we've been also trying to help them with some of the TIVA simulations apps that allow you to use different models of TIVA depending on the drugs, and then how do you adjust? It takes a little bit of effort and calculations, but you can do, depending if you're using a macro drip or a micro drip, to determine how fast your milligrams per kilo per hour. And so you can use your target dosing based on that. And that's how you control, kind of like going back to the 1950s or 60s, but that's how we would run, that's how they would run the TIVA in underserved or poor countries. Then my comment on the genetic testing, I think it's great, from being able to get it done to then get it classified. Nowadays, you can do it. You can take a sample, whether it's blood or a swab, and it will take 2 to 3 weeks. We're already started doing it in our center. But we've heard from other, like the director of pathology or the director of the lab, great ideas that I think, similar to what happened with COVID recently, we didn't have a way to test it, and suddenly now we don't care about COVID, but we are doing tests that within a couple of hours we would have the results. Suddenly, this might be the future where I envision, where somebody designed a genetic chip that with a swap you can rule out all anesthetic major risk factors, whether if it's MH, acetylcholinesterase deficiency, this disorder, or muscular dystrophies. Just with one sample, you have a chip that is sort of like the anesthetic cassette or chip that will rule out all the major diseases that will get you into trouble if you require anesthesia, which gives you hope of the future and where we are. And once this is done, hopefully this can be spread in a financially viable way for poor countries and provide safer anesthesia to all those in the poor developed countries.
And that's the importance of putting experts together, right? Because you see, like he's talking about pathologists, we're talking about mitochondrial experts, pediatricians. We need to put the big brains together so we can make this easier for all of us.
I like that. I like big brains. Jim, not that you have a big brain. No, I'm sorry.
One of the recommendations, I just want to follow up with what Louise said, is processed EEG to avoid burst suppression. There's a suggestion that could be useful, but it's unknown in this specific condition and clearly is not even available in all U.S. hospitals. So some of the recommendations I think are very conservative and very much a technology-laden program. When you look at the ASA SPA recommendation, that's not something that's going to be available everywhere, but avoiding burst suppression would be a reasonable thing to consider.
Since we're getting close on time here, since all four of you are from different institutions, I would actually love to just ask each of you what your institution is doing, both about screening and if they've been able to screen. I think, Veronica, you had mentioned the importance of screening across departments and not just anesthesiologists, but surgeons and other proceduralists and pediatricians. What are your departments doing about screening? And then what are your departments doing about anesthesia recommendations to the members of the department? And I'm going to go just in the order that you're listed on my screen right now. So that's all, there's no anything. So Luis, you go first.
Okay, thank you. So in our center, basically, since we are seeing between 10 to 15, I'm in South Florida, so obviously high population, we get to see between 10 to 15 Venezuelan patients who are potentially at risk, meaning that they have a mother or grandmother that is Venezuelan. So
10 to 15, is that a week, a day, a month?
10 to 15 patients a week.
A week, wow.
So like tomorrow we have a surgeon that's bringing 3 cases that are all out of his caseload. 3 of them are from mothers or kids from maternal inheritance from Venezuela. So very high incidence or frequency of our patients. Here we are all asking the typical questions of anesthetic complications or risk, putting focus on any neurologic, as Claudia was describing at the beginning, and especially looking for those signs that seems to be very common in all the cases we've heard, is delayed emergence in any family member or any potential complications. Sometimes if the family members had surgery in Venezuela and they say like, oh, they told me I'm allergic to anesthesia, or oh, they told me I had a laryngospasm during anesthesia in Venezuela, we consider that a risk factor just because since there's very limited information and access to records there, we consider any complication, especially coming from Venezuela, kind of like a risk factor. The other important thing to understand is when you're screening for these patients is in a particular state called Carabobo. It's kind of like most of the preliminary data says that the majority of patients have an inheritance that comes from this area. Just by being from this state will put you at 15 times the chance of having this mutation or running the risk of the complication than any other state in Venezuela. But as we know, this is something that will eventually blur out and it will be just another risk factor just to come from Venezuela and later from anywhere like an age. You just have the risk factor if you carry the mutation. So we do the screening, we do the questioning, and those at this point, if we have those who are actually test in our pre-anesthesia clinic that they have the risk factors, we actually talk to the surgeon, and if the surgery is not urgent or emergent, then we might consider delaying and talking directly to the family to delay and send to the genetic lab to get tested. We've already sent 3 of them, and we're working with our lab to see if we're in the process of getting like a PCR testing soon to be tested. So we are working on that aspect, and our goal is to be able to not just test Venezuelan patients, but start doing a epidemiological study here in South Florida to determine what's the frequency here in South Florida, not just in Venezuela, but anybody that comes to the hospital.
And then what are you doing for the anesthesia part?
Basically, what we're doing is in any kid or any patient that comes in that has either a positive family history of complications or just at this point that the mother or the grandmother come from Venezuela, in particular of this state, we're doing TIVA. So we are in our center, we are using propofol as part of our TIVA. We are using this in cases where we can and have it available. Sometimes the demand is higher than the number of these monitors we have. So we titrate as good as we can, and we are using some of the TIVA simulations to help guide us in the use of the TIVA. And we do not depend on one medication, but we try to use a balanced TIVA with multiple medications, whether it's dexmedetomidine, propofol, some sort of narcotic depending on the procedure, and definitely midazolam or any other medication or ketamine.
Great. Jim, how about you? What are we doing at Stanford?
So first, being aware of this, and there were only 5 kids, which I don't say only as a small thing, but it has grown substantially now that there are 35, either deaths or significant disability over this 6-month period. With the more recent statement, one of our physicians, Dr. Janice Mann, has led the efforts to create what I would say is a sensitive approach in asking. We have made our adult colleagues aware. Certainly, they're aware of this situation, but most of these patients will be in the pediatric realm. We will be screening all patients, and we are screening all patients now for maternal Venezuelan or maternal grandmother from Venezuela heritage, and then would suggest similar anesthetic to what Luis said. We also have SED lines, so we would use the processed EEG monitoring, and there's a much smaller population from Venezuela in the Bay Area. So we haven't had a huge number, but certainly some patients come through from with a mother or grandmother, maternal grandmother from of Venezuelan heritage. One of the important things is diseases become stigmatizing for individuals. You think of HIV and how Haitians were singled out unfairly for in the 80s, those of us who were around at that time. And similarly, Venezuelans, who are some of the most productive members, immigrants, or many generations in the U.S. of Venezuelan heritage. This diaspora that has happened, it is some of the intelligentsia and some of the brightest individuals have settled in the U.S. This is, again, a mitochondrial disease that we need to approach with sensitivity, especially when families are concerned about being able to access health care. We are responsible to everybody's children. And our concerns in creating our screening has been formed with our office of, or our lead of health equity in our children's hospital, with our Latinx Council and the Family Advisory Council, to make sure that we had the proper tone and, again, sensitivity to all of our patients so that they can get the care they need when they need it and feel safe to do that as much as we can make them feel safe.
Claudia, what do you do at Cincinnati?
Well, at Cincinnati, this was a whole process. When we learned about one case that happened in U.S., we started pushing for getting involved on leadership level from several departments: genetics, surgery, anesthesia. We started screening for patients' ancestry pretty early. I will say around November, we were already screening. We had a Spanish group, and we involved like a Venezuelan focus group in the hospital to get their input about how they wanted to be screened, what was the right way of doing this. And I think that was very helpful, because from these, we were able to come up with a script that we gave to our nurse practitioners. And then we started screening as part of the pre-op. And most importantly, we screen universally, not only Spanish-speaking patients. This is important. We have to screen everybody, right? And so one of the things that we were able to do was that we implemented this screening question in our EPIC as part of our pre-op evaluation. And then we came up with a group, myself included, to work with a guideline or recommendation. We call it more like an action plan. We can really call it a protocol, since protocol, we know it's evidence-based and there's more unknown than known for this topic. But we created this guideline to give recommendation as to the rest of the department and a background on what was the issue we were working on. We have this nice table where we try to give recommendations on TVAS, different anesthetics that you can do: remifentanil, Precedex, ketamine, remimazolam we started using recently. And then, of course, boluses of Versed or any opiates is fine. Yeah, I mean, there's a lot of work in progress. We also came up with an algorithm on how to have a discussion with family, when to proceed or not proceed. We are aiming to offer always alternatives. We don't want to delay cases just because they might be at risk. We have to provide care. But of course, if families don't feel comfortable proceeding and they just want to pursue genetic testing before, that's something that we are offering at our institution for sure. And then the availability of BIS or SedLine. We do have EEG for certain surgeries, mostly spines. So we don't have the availability to do EEGs on everybody. But if we have that during the day, then we try to get it.
Great. And last but not least, Dr. Zogby, Veronica, what do you guys do in Miami?
Well, it's very funny because Luis and I work in the same city, and we have close institutions just a few miles away. But I don't have as many. I mean, my perception is that I don't have as many Venezuelan patients as he does every week. But we are in Miami, so the population here is very vast, Venezuelan-wise. So we do get Venezuelan population. So we've been screening in clinic. We have two settings. My university gave a pediatric anesthesia to two main hospitals. One is a community hospital, and one is more like a well-resourced hospital. So the pre-op clinics are a little bit different in both. So we're in the process of optimizing, our process in the pre-op clinic. But we're mainly screening in the pre-op clinic in the day of surgery. We're doing TIVA when it's necessary. When the kids are small and you have to get an IV pre-op, we're giving PO Versed and getting the IV. And then we are using the BIS monitor. We do have it available. So we don't have SedLine, but we do have BIS. So we're using that. And then as Claudia was saying, we're trying to use a multi-medication type of anesthesia. So decreasing as much as possible the propofol use, but using our TIVA and doing adjuvants to give the anesthesia. And mainly, we are going to probably optimize our process. We have actually a meeting tomorrow to optimize this process further.
Oh, this is wonderful. This has been such a great discussion. I've personally really enjoyed it and learned so much. We're well over time, but that's okay. This is an important topic and we needed to talk about it. Before I close, do any of you is there anything we didn't talk about that you feel like our listeners should hear or know about? And again, I'll start backwards this time, and I'll start with Veronica. And then I'll go Veronica, Claudia, Jim, and Luis. So Veronica, anything that we should know that we haven't already discussed? I'm sure there's tons that we should know, but in the interest of time.
I think as a team, we were discussing this previously, and I think it's very important to see the anesthesiologist in these cases as the second victim. I think it's very important to provide support to if this ever happens in your institution. And we hope that all of these measures that we're doing prevent further cases. But it's very important to provide care to these anesthesiologists. We have had several records of anesthesiologists that have stated that they have even left the field after this has happened to them, because they were not supported, because at the beginning they thought it was a malpractice or everything that they have done, and they felt guilt. It's very, very important to know that the mothers of some of the patients have disclosed to these anesthesiologists that it was a genetic mutation years later, and it has provided so much comfort to these anesthesiologists. And I think it's very important to know that and to have resources for people in those hospitals too.
Thank you. That is such an important point. We as anesthesiologists and physicians feel that intense guilt if something bad happens, and especially if it is a child, even though this also happens in adults, but it sounds like young adults. So thank you for bringing up that point, Veronica. Claudia, any last things that we should share with the listeners?
Yeah, as Veronica was saying, this is very rough. This is a tragedy for all the teams involved in the care of these patients with this terrible outcome. Just support each other. We have heard of, unfortunately, anesthesiologists that have quit, anesthesia because they thought it was too stressful. Unfortunately, from anesthesiologists back in Venezuela, where it was seen as common to have this type of complications, but it really is not. So just, have the support. Don't be afraid to speak up. If you suspect a case, if you think about, maybe, 5 years ago, I had this case that kind of fits this pattern that we're hearing now, try to reach out and try to speak up. Try to report it to AIRS, Wake Up Safe, or reach out to any of us. This is a very evolving topic, so keep your minds flexible, and that things will change. And as we discover more and more information, and most importantly, just understand that this is a kind of like a new rare disease. But also, this is rare, right? That doesn't mean that every Venezuelan will have this variant, okay? We do have to screen because that's the way we avoid more cases. But I don't want people to think that every Venezuelan will have this outcome, okay?
Great. Thank you, Claudia. How about you, Jim? Anything that we didn't discuss that you feel like we should let the listeners know?
I'm just grateful to our colleagues here who are leading the front of trying to confront this new condition, and would echo what Claudia said, that all of us would be available, and we can all be contacted as friends of Rita. So contact Rita and she can get a hold of any one of us. Down in Miami, here at Stanford, Cincinnati Children's, Nicholas Children's. This is important not just to take care of any patient we're taking care of in our institutions, but for children everywhere. And if you don't know, we are all here to support each other, both in the U.S., North, South America, and throughout the world. That's important.
Absolutely. And please, yes, my email will be on the show notes, and CSA listeners should hopefully know who I am by now. So if not, you can always get in touch with me through the CSA. So absolutely, you can get in touch with me, and I can put you in touch with any of the members of this group. Luis, are there any last words that you would like to share? You get to go last, and then we'll close up.
Thank you. So the first thing and the main message for me or for the group is, one, thank you everybody for sharing their knowledge and helping us. But to every anesthesiologist there, don't undermine the value of the education we can provide to our patients. When you do the screening, sometimes even though this screening can feel or look or sound politically charged, take your time to prepare your own set of words and explain why you're asking this. Once you explain to these parents why you're asking, why if they're from Venezuela, they understand. And even though the patients might not have any inheritance or maternal ancestry, they are the source of information for their communities. So you can say, hey, if you have Venezuelan friends or neighbors, tell them to dig in and learn about their family history. Knowing this can potentially save the life of your child if they need anesthesia. So this is critical to share among the community and make them aware of their family history. And that's where us as anesthesiologists can serve as a great point of being educators to the community and to all our members. And finally, Rita, if you give me the chance, it's to thank the group of the Vapor Group. We have physicians, researchers, microbiologists, geneticists that are in England, Canada, all across the US, Venezuela. We have some friends in Chile, all working together, and I cannot thank them enough because this is such a vast project to understand these that nobody can take alone. And working with this group has made us, I feel that, so much smarter, and it's extremely valuable to have this power of the group to increase what we know and the best way to collect the data so we can understand this disorder more. So thank you so much.
Well, thank you all. And Dr. Ruggiero mentions, sorry, I'm going to just say it, but we also need to thank all the families who have shared their stories and their experiences with us, and as well as all the initial anesthesiologists and others who identified this as a disease. This just sounds like, it sounds like probably the early days of malignant hyperthermia research felt, where you have this horrific thing that can happen and cause major death or terrible neurologic complications. And so much is still unknown. So thank you all. Thank you to the group. We will have some show notes that will have some links in there to other information. Once you do get your website for Vapor, we'd be happy to share that on the CSA website. And I want to thank our listeners for joining us for another episode of Vital Times, the podcast.